Well, thank you very much for having me today. And I was asked to talk some about survivorship after childhood cancer, which is a large topic, but we're going to try to cover some information today. And Leslie, I'll ask you to tell me to slow down if I'm talking too fast. And I thank you for the lovely introduction.
You're used to me, so I think we're good.
Okay. I take care of children, young adults, adolescents after childhood cancer therapy. And there's a lot that's known about what happens after childhood cancer treatment, but there's a lot of unknown as well. And so I'm going to really kind of hit some major themes. So it'll be some broad overviews and hit some specifics. And we won't hit everything, but just to begin a discussion about childhood cancer survivorship today. So as you know, with increasing cures for childhood cancer, that comes with increasing numbers of long-term survivors. But we've learned over time, and we can see with our patients, that there are some costs of this cure for patients. Early mortality, we'll talk about that, the risk for chronic morbidities, the risk to have a subsequent malignancy down the road, and potential for psychosocial impact, among others. And all of this can lead to care needs in later childhood, adolescence, or into adulthood. And in terms of terminology, some people talk about long-term and late effects. Long-term effects can be thought about as adverse health outcomes that occur during treatment, during your cancer therapy, and then persist. For example, your kidneys are injured, and then you go on to continue with renal issues. And late effects end up being spoken about as adverse health outcomes experienced after treatment. So longer term issues that develop later on as a result of having had treatment for childhood cancer. And some of these long-term or late effects can be life-threatening and contribute to a risk of early mortality. And others can impair quality of life, such as neurocognitive impairment, if there's a physical deformity, or if there's infertility as a result of childhood cancer therapy. And all of these issues kind of get put into the thinking about childhood cancer survivorship. To talk about childhood cancer survivorship, just to highlight how we know what we know now, it all began with clinical observations, seeing what happened with individual patients, then single institution descriptive studies, and then putting it together with larger multi-institution descriptive and analytic studies, which we'll talk about very, very briefly, just as a backdrop. And then what's known about late effects is always a moving target because treatments change over time, and that makes it complex too. I'm only going to talk about this very briefly, but to say a lot of what is known about late effects after childhood cancer treatment comes from a study that included over 35,000 survivors throughout the United States and Canada. You had to have been diagnosed when you're less than 21 years of age, and you had to have been at least 5 years from your cancer treatment. And these are patients who were treated in the 70s up into the 80s, and then another cohort into the 90s. And so now they're long-term survivors. There was detailed treatment data, and then there were sibling controls to compare. And the major endpoints of that study were to learn about mortality, second cancers, and cardiac disease, but all kinds of topics have been looked at. And what we've learned and see from that is this is compared to the US general population, that the all-cause 5-year mortality for patients treated in the 70s and 80s was certainly less than the US population. We won't spend long on this, but just to give a backdrop. And that initially, what the cause of death, when we think about cause-specific mortality, was recurrence. That makes sense with what we think of clinically. But over time, other issues, chronic morbidities of childhood cancer therapy became the issue and the cause of early death at 25 years and beyond after treatment. In terms of what we know about childhood cancer therapy and the potential risks, in survivors treated in this time period, by 30 years after their cancer, so longer term, about 3/4 have a chronic condition, 3/4 of patients, and 2 out of 5 have a severe or life-threatening condition. And patients were 8 times more likely to have a severe or life-threatening health condition than their siblings. And then this is again from this large data that has been replicated. The relative risk of a chronic condition compared to siblings of severe or life-threatening or more disabling conditions were high, highlighting just a few of congestive heart failure, for example, or of second cancers. When moving on from that, when we think about late effects, we tend to also think about what puts somebody at risk in terms of the treatment factors itself, and then thinking about the individual. Some of the general things that could predispose to risk that we think about is the time since treatment. Some issues are closer to the time of treatment, and some happen much longer term. The dose and intensity of treatment, we'll talk more about that. Concurrent treatments, there are some treatments that if you've had them both, it can put you at more risk. An example of that is anthracyclines or doxorubicin that can cause cardiac issues in the long term. If you've had that as well as radiation to the chest, that together really compounds risk. Prior treatment toxicities can also predispose to future toxicities. And then we also think about the individual, their age, their developmental stage. We'll talk more about that as well. And one of the challenges about thinking about late effects of childhood cancer therapy is there's a trajectory. The issues that you have at one point in your growth and development are not necessarily the same as later on. An example of that is with ovarian dysfunction. So alkylating therapies like cyclophosphamide at high doses can predispose to ovarian dysfunction. And if that occurs in a young person and they don't go through puberty, that's an issue at that time. That can result in it later on in development of the consequences of infertility, and then even later on, still issues with osteoporosis. So it's not static. There are issues that can change with regard to where you are in your age and development. It can be helpful to have an approach to thinking about childhood cancer survivors. And in general, what's helpful is to start with thinking about the exposures. And we can consider the exposures in their categories of chemotherapy, radiation, and then the surgical complications as well. And we can think about systematically about the exposures and their impact on organ systems, on future cancer risk, and on growth and development moving forward. With organ systems, we can think about toxicity to the cardiovascular system, for example, the GI tract, pulmonary. We'll highlight some of these a little bit more. In terms of cancer risk, we can think about the risk of future solid tumors, for example, in areas that have had radiation, for example. We can think about risk of subsequent leukemias, for example, with topoisomerase medications such as etoposide. And we can think about for those with maybe a genetic risk if they might have tumors again. And then really importantly, when you're thinking about childhood cancer survivors, we think about growth and developmental impact, the potential to affect linear and skeletal growth, neurocognitive function, emotional, social development, pubertal development, and reproductive health. These are just examples. So we're going to think about these categories, chemotherapy-associated morbidities first. In general, as a theme, higher cumulative doses can be associated with greater risk. That's defined and more the case for some chemotherapeutic agents more than others, and we'll talk about that, but just as a general theme. And that knowledge over time has adjusted and changed regimens so that we're hopefully causing less toxicities. And I was able to, your team shared with me some of the regimens that are being used, and many of them were chosen with these issues in mind, trying to limit higher cumulative doses with known associated greater risks. Some of the kind of classic and things that we really think about risks to organ systems is cardiac toxicity with anthracyclines, which we'll go in more detail about, bleomycin, which predisposes to pulmonary toxicity, platinum compounds that really can affect the kidneys, but really hearing in young children, alkylators, which at high dose can have reproductive risk, steroids, which can cause cataracts, which are generally vision sparing, but important to be aware of. And then alkylators and topoisomerase inhibitors can predispose to leukemias in the future. Alkylators, that tends to be multiple years later. Topoisomerase inhibitors, that can be within the first several years after treatment. And then Chemotherapy risk toward growth and development can be, for example, an example of that is intrathecal chemotherapy, so important in ALL therapy, which can have some neurocognitive effects. From a radiation perspective, just generally, anything in the radiation field can be affected in the long term, but doses and field are thought about in that way, and there's been changes over time to use radiation more safely. In general, the idea is for survivors is to consider the field and the dose, with larger field and higher dose exposure associated with greater toxicity. One of the things that I'll highlight here is the issue of thyroid function. The thyroid is exquisitely sensitive to having had radiation exposure. And so those who were treated at young age with radiation that could affect the thyroid, so that includes to the chest, to the neck, even to the head. It's one thing that is more simple to do, but important is to think about the risk of hypothyroidism and to be aware of the signs and symptoms of that, because that's something that can be corrected and treated. A major issue with radiation is the risk for cancers in the radiation field down the line. That's not usually immediate. That's usually a longer term risk, 10 years plus after radiation therapy. And then something that's not always thought about, but is still true, radiation can have risks to growth and development, such as growth hormone insufficiency when that axis is disrupted, cognitive function if high doses are used in brain tumors, for example. And then local radiation can have its issues too, bone hypoplasia, for example, or scoliosis or loss of spine height. But again, and none of that has to be known so much as really thinking about the field and dose, with higher dose and larger field predisposing to greater toxicity. We won't look at everything on this, but I just put this here to say another way to really think about and conceptualize thinking about the organ systems is just go from the head down and think about what treatments were delivered from a chemotherapy perspective and what treatments were delivered from a radiation perspective in order to think about that exposure and what long-term risks there might be. And I'll just highlight a few. Again, anthracyclines can predispose to cardiomyopathy. Bleomycin to pulmonary fibrosis, alkylating agents to hypogonadism, infertility. Corticosteroids of any form, especially in ALL therapy, can predispose to osteopenia or decrease bone mineral density, particularly in the short term on treatment and in the immediate time period after treatment. It's still less known whether that's a risk in the very long term, but you may see fractures on therapy or soon after therapy with the use of corticosteroids in young patients.
Lynda, can I ask how you think about anthracycline dose and like cumulative anthracycline dose and cardiotoxicity? We actually, or if you're going to get to that, fine, but
I'm definitely going to get to that. And if I don't, please bring it up again. We'll get to that specifically.
Great.
Because you're right, these are generalities, but then when you're talking about the actual patient, the cumulative dose does matter for these things. And then kind of generally also surgical associated morbidities, which again are not always thought about, but are very important because surgery is a large part of the cures for many types of childhood cancer. Small bowel obstruction risk after abdominal surgery is patients who are treated for Wilms tumor decades and decades and decades ago, and also probably had radiation as well. We have seen many patients have serious consequences of small bowel obstruction later on. There can be neurologic and cognitive impairments after neurosurgery, scoliosis after paraspinal surgery, and potentially chronic pain after some orthopedic surgeries. But something to highlight very practically is that after there's been a surgery with paired organs, it's important to have long-term attention to avoiding toxicity in the remaining organ, for example, kidney or eye, if there's been surgical intervention or insult to one of them. And this is going to bring us to your question, Dave, just kind of highlighting through a few cases. A 24-year-old with a history of osteosarcoma, diagnosed at 12 years of age with a doxorubicin dose of 375 milligrams per meter squared in the setting of pregnancy at full term, presented with shortness of breath and was diagnosed with congestive heart failure. So we're going to think about a little bit about anthracycline exposure and cardiac toxicity here. So with increasing cumulative doses of anthracycline, this could be associated with an increased risk of cardiomyopathy and congestive heart failure over time. It's also true as an acute toxicity that doxorubicin rarely can result in acute cardiac compromise, particularly at high dose. But here, in terms of the long-term effects, we know a few things about this, that higher doses, particularly when you start to get over 250 milligrams per meter squared of anthracycline, there is a risk. What's really true is that much higher doses, when you get to over 600 milligrams per meter squared, 700 milligrams per meter squared, 800 milligrams per meter squared, as I was saying, we used to learn all of this through single institution studies or observation. When before it was known and doses went that high, there was a very high rate of congestive heart failure and risk. But with what's known now, we try to keep it much lower, as you are. But still, with doses over 250 milligrams per meter squared, that seems to be an inflection point where there is a higher risk. With doses less than 250 milligrams per meter squared, seeming to cumulatively seeming to confer less risk. But not no risk. And that's important to keep in mind. The other piece is that the other exposures that you have matter. Having had anthracycline exposure and chest radiation, for example, Hodgkin lymphoma, for example, that may be relevant. That results in a higher risk for those patients. Some of the other factors that can be thought about that place patients at somewhat higher risk are younger age at diagnosis. Females seem to have a higher risk. And then a longer time since exposure. Because unfortunately, this doesn't seem to be a risk that you have for a little while and then it plateaus and it doesn't occur anymore. There does seem to be a continued trajectory of the curve. That said, these risks are much lower than with even higher doses. And so many treatment protocols, and I believe the ones that you're using as well, keep the total cumulative anthracycline exposure more at the 300, less than 400 milligrams per meter squared dosing. In which case there does confer to be much less risk, but it still is something that can become an issue. And when can it become an issue? Anthracycline-associated cardiomyopathy can become evident with the small case I just highlighted in pregnancy and in postpartum. Even patients who have had no clinical issues, that's a time of risk and something that we counsel patients about because that's a time with more stress on the cardiac system and where patients can present even with congestive heart failure at that time as a consequence of having had anthracycline. Maybe more rarely, but it also can be noted in adolescence and growth spurts or in the stress of anesthesia. Are there any questions about that? Dave, did that help highlight your question?
Yeah, I think, I mean, I think you hit the nail on the head especially for our young patients. We do have some patients who get between 300 and 350 mg per meter squared of dox. Our high-risk Wilms patients fall into that category right now, and certainly bone tumor patients who tend to be a little bit older when they're treated. So I think a really useful thing to keep in mind.
Those are still relatively safe doses, but there is the potential with those, and especially I would say in the setting of pregnancy. So this just highlights some of these issues as well in terms of radiation-associated morbidities. A 24-year-old diagnosed with acute lymphoblastic leukemia at 10 years of age, treated with multi-agent chemotherapy for over 2 years, and whose treatment included cranial radiation, 1800 centigrade, which over time is used less and less, but there are groups of patients who receive cranial radiation still and for other reasons as well, presenting with symptoms of several months of intermittent headache. And this is imaging that showed a frontal mass, which underwent resection, and the pathology of this was a meningioma, which tend to be localized and don't tend to, they're not metastatic in that way, but they can be space occupying, and depending on where they are, can cause significant issue. I'm not going to highlight this too much, but to say radiation-associated tumors are an issue down the road after having had cranial radiation, even lower dose, but it is dose dependent. Most pathologies are meningioma and glioma, and there certainly is a higher risk in this population. with meningioma being of particular risk down the line. With radiation dose, with increasing radiation dose, there's increasing risk. And this is not an immediate risk, as we kind of highlighted earlier. It's a risk that can start many years, 10 years plus after treatment. And so as this patient presented, symptoms of several months of intermittent headache can be what we see. Sometimes the presentation can be seizure. Sometimes the presentation can be vision changes, all depending on where the subsequent tumor is located. And so subsequent tumors in the radiation field, there's a risk no matter where the radiation field is, but obviously intracranial and brain tumors are one of the things that are most worrisome after having had cranial radiation. Another important and well-described risk was presented here, a 29-year-old diagnosed with Hodgkin lymphoma at 15 years of age with radiation to the neck and mediastinum. There are multiple potential risks here, risk of breast cancer later on, thyroid cancer, and then skin cancer risk, for example. We highlighted earlier that the thyroid is exquisitely sensitive to radiation, and that puts you at risk for hypothyroidism. But also there's the risk of nodules, benign and malignant, when the thyroid has been affected by radiation. Breast cancer risk is well described, particularly in Hodgkin lymphoma patients. Females treated with mantle, mediastinal, chest, spinal, whole lung radiation during childhood or adolescence are at risk of secondary breast cancers. And secondary breast cancers are most often described in Hodgkin lymphoma with a 15 times to 30 times increased risk compared to the general population. With women treated with radiation for any childhood cancer at increased risk as well. And the greatest risk seems to be for those treated between 10 and 30 years of age and with radiation doses greater than 20 gray. There is here also a linear dose response relationship. The higher the dose, the greater the risk. And it's also been seen that survivors of primary sarcomas not treated with chest radiation also have an increased risk of breast cancer, and that may be due to genetic predispositions. This is just to speak to patients with childhood cancer who did not receive chest radiation, who did receive chest radiation. And this blue line here is Hodgkin lymphoma in terms of cumulative incidence over time of breast cancers. And this kind of highlights well, I think, the dramatic potential for this complication. It's very hard to summarize all risks to all patients in 20 minutes, although it looks like we have a little bit longer, so that's great. So there'll be a lot of time for questions. A resource that is helpful to look at the risks themselves that get defined is the Children's Oncology Group exposure-related guidelines. Not all of the guidelines themselves are relevant to everyone, but really define well what risks can be associated with particular exposures. And this can be found just by searching the Children's Oncology Group long-term, and there's no passwords needed to get to this document, which can be very helpful in thinking about what childhood cancer exposures are associated with what risks. And I think what's great is we do have some time for discussion and questions. And here, these are some considerations and thinking about childhood cancer survivorship care. Childhood cancer survivors are described and known to now be at lifelong risk for adverse health outcomes. And these risks for late effects change over time and are influenced by developmental changes. So the risks, again, are not static. It's something that has to be thought about in terms of somebody's development. There are higher risks associated with radiation in general. Patients who have received radiation are in general kind of higher risk survivors in terms of the issues that they face, and particularly the risk of subsequent cancers 10 years plus down the road. It's possible to have subsequent cancers after radiation earlier, particularly thyroid cancer can present earlier than that at the 5-year mark. But in general, those cancers tend to be later on. And the other theme is that higher doses of some chemotherapeutic agents also place patients at risk. We highlighted anthracycline, doxorubicin, the anthracyclines in terms of cardiac risk, but that's also the case, for example, with alkylating therapy, cyclophosphamide, which would be used in multiple regimens. Higher cyclophosphamide and alkylator chemotherapy is associated with higher risks of impact, for example, to the reproductive system, to ovaries, to fertility in males and females. So again, higher doses of chemotherapeutic agents can place patients at more risk. And this knowledge informs the treatments that you're using, but even still, with the best possible treatment regimens, these risks can still exist. And then there's also diversity of treatments for childhood cancer. The treatments are different for each thing that we're treating, and those treatments change over time, and that affects that's challenging in terms of thinking about childhood cancer survivor care, because that's a lot of knowledge about the different therapies and how individuals might experience the consequences of that over time. And that's a challenge in the care of childhood cancer survivors in any setting. And then something we haven't talked too much about, but is important to just highlight, is that patient education is an important component of survivorship care, because survivors are, in general, when they go on to do what they're going to do and live their lives, they're generally not coming back to the same place where they received their childhood cancer therapy. And one of the thoughts about childhood cancer survivorship care is it's important for survivors to, as best possible, understand what their risks may be, so that they can also advocate for themselves, so that when they have a headache like that that's persistent, that's thought about differently in that 24-year-old than another 24-year-old who didn't have the exposures that they had. And so patient education becomes an important component of survivorship care. I know I can keep talking and head back to that general picture of the organ systems and talk more about individual chemotherapeutic agents, but maybe we can stop there and see if there are questions.
Lynda, I have a quick question. First of all, that was absolutely excellent. One question that I had for you, it was kind of a practical one.
Sure.
Just in terms of how you actually are following these children as they move into adulthood. Do you, for every disease, do you use in your clinic specific protocols for following these survivors down the road? Or I mean, it seems like there are so many different variables between the drugs and the doses, you know, radiation, no radiation. But for a particular patient, you know, say a child who had Wilms tumor who received, you know, trimodality therapy, and you're following 10, 15, 20 years down the road, do you have a specific protocol that you would follow for that child?
So that's a great question. And one of kind of the things that we think about is making some kind of a survivorship care plan for the patient. So kind of laying out early on what based on their exposures, the kind of follow-up we think they're going to need. In the initial, and I didn't highlight this much, but in the initial time period after treatment, in the first, you know, and this ranges by the diagnosis, the risk is really cancer recurrence. So it's not just the long-term consequences of therapy that you're looking for, but you're actually monitoring for recurrence. And often that monitoring for recurrence drives the kind of the frequency and how often we're seeing patients in the initial few years. But in the longer term, in survivorship, we think about the treatments received and creating survivorship care plans for patients, because you're correct, not everybody needs the same thing. And we do kind of have, we do think about it in terms of risk for survivors, kind of just as we think about risk when we're thinking about the treatment that somebody needs on therapy, we think about their risks or survivorship issues. So there are patients who we end up seeing yearly, those with multimodality therapy, as you're speaking to, particularly those who have had radiation. Maybe we're having them come every year to every few years. There are patients who are treated, for example, with standard risk ALL therapy, who are thought to have lower risks of long-term issues. And we may transition them to providers in the community in our setting, or and check in with them and have them return every 5 years or so. We kind of tend not to let anybody go forever just because we're still trying to learn, gain data, and because we are, as we learn more, sometimes we learn more about risks even for patients that we didn't think there were risks for. So we generally don't dismiss patients entirely in our setting. These survivorship care plans we kind of have general ideas for each disease and each kind of type of therapy, exactly how we're going to lay that out. So for a patient with acute lymphoblastic leukemia who was treated with high-risk therapy with anthracyclines to 300 milligrams per meter squared and may or may not have had cranial radiation, then we would lay out that for the first 5 years, we're seeing them after their immediate period of follow-up. In the first few years, we're seeing them yearly. Then we move to every other year. And then we would make sure that they had a treatment summary, which summarizes their treatment, because here and elsewhere, patients don't stay where they were treated and they're out in the community or elsewhere, so that they have a record of the treatment that they received. That's kind of our approach. So that's a long way of saying, yes, it's not so much a protocol as in, it's individualized to the patient, but we do have that so that we can be clear with patients and they know what to expect. It can be very, as patients experience long-term effects of their treatment, that can be profoundly stressful, especially subsequent malignancies. And one of the things that can help with that is having a good plan and having patients understand how we hope to monitor them.
Thank you.
Lynda, this is Lori.
Hi, Lori.
Just to follow up on that question a little bit more, the website for resources that you showed, are there any tools where a clinician could put in the diagnosis, the age that the patient was when they received treatment, what they received as treatment, and then have that care plan developed based on the risks associated with that particular patient? Or does the clinician have to know the wide body of literature around late effects in order to build that care plan?
In general, I think that website that I showed you and other resources are really good at laying out what the risks are. But then what you do with that risks, it doesn't kind of lay that out or spit that out, as you're saying, in the same way. And part of that has to do with those guidelines are not relevant in all settings. And I'll say we don't necessarily do everything that they say. It talks about the exposures and then talks about how you could monitor for that. But one of the issues is often that you have to streamline that so that it's appropriate for the patient. So, but there are some real themes. Higher dose anthracycline and how we think about that, radiation exposure and how we think about that, and then what the risks are to different organ systems and how you would want to be aware of that for the future.
Thank you.
So one question.
Yes.
Yeah. I'm asking a question, just a question about trajectory after late effect ovarian and the testicular, for example. Do you have an idea of the reversibility of some organ dysfunction like ovarian or testicular? Or when you are treating, do you somehow in your in your high standards centers, do you monitor sometime the organ dysfunction?
So do we monitor for organ dysfunction with regard to the reproductive system? Did I hear correctly?
Like ovarian, yeah.
Yeah, ovarian, yeah.
Exactly.
So that's a really great question, which is something that's definitely evolving over time. We do have patients for whom we think they've had such high dose alkylator therapy that we are very concerned about ovarian dysfunction. And ovarian dysfunction has the piece about estrogen and the ability to go into puberty and that piece. And we do, with our endocrinologists, work closely to monitor patients in order to supplement and to manage that. And then there's the piece about infertility. Patients who have had normal, for example, normal menses, have the appearance of decent ovarian function from that perspective, but then their fertility is in question. We do tend to follow something called anti-Müllerian hormone. AMH is a laboratory test, but that's imperfect. And we do, patients who are really are interested in that may have may speak with fertility specialists as well. So there's the ovarian dysfunction piece in terms of the function of the ovaries for growth and development, and then there's the issue for fertility. And we are monitoring with endocrinologists for the patients who are at highest risk of ovarian dysfunction.
My last question is the neurocognitive during intrathecal chemotherapy. So, some of intrathecal we give for prophylaxis, but when you look about the late side effects, maybe what do you think the dose maybe sometimes can, or the time duration of the intrathecal chemotherapy, what balance you can keep doing or keep doing when it is necessary? What do you think about comparative to neurocognitive side effects and when it is prophylactic?
So
Bad, heavy or bad
therapy and particularly with ALL. So as you know, ALL can't be cured without treatment to the central nervous system. And in the distant past, we did that with high dose radiation, and that's bad. And then there are still patients for whom some radiation is used, prophylactic radiation. And the way to treat and cure patients without radiation or with less radiation is the use of intrathecal therapy. And without it, we can't cure patients. Luckily, the way that intrathecal therapy is used in ALL therapy, it's generally, as you've seen, well tolerated, and it doesn't seem to have effects on intellect and IQ. Maybe sometimes people think about it that way, but there are studies that describe that exposure to intrathecal therapy over time can have some subtle issues with learning, sometimes with something that like executive function, like multi-processing. But there are many patients, the vast majority, who do exceedingly well after intrathecal therapy. So one of the problems with having a talk about childhood cancer survivorship is we can lose track of all the children who do so well. And ALL is a success story of that. So there is a risk of some neurocognitive issues with intrathecal therapy, but in general, it's well tolerated. And those issues can be really around kind of complex functioning, executive functioning, thinking. It's an issue no matter who you are. Nobody wants their child to have treatment that can affect them their neurocognitive function. But in general, ALL therapy is overall well tolerated. And those issues can be subtle, but it can be helpful for patients and families to know that there can be some subtle issues with learning. Of course, there can be more acute toxicities, more serious toxicities with intrathecal methotrexate, with intrathecal treatment in the acute setting. And if that occurs, there can be much more serious long-term consequences. And kind of thinking of a long-term effect, if you have the toxicity on treatment, that can go on to be an issue in the longer term.
Nice, thank you.
I could ask, I guess, make a comment. So thank you. That was certainly quite excellent. One of so this it's sort of a follow-up to what Scott and Lori was asking with regards to so and also what you mentioned, the risks are individualized in some ways. So the assessments need to be individualized. However, I think given the way we treat patients in Rwanda with protocols, I think we could in fact have survivorship plans for the different protocols that we have. Yeah. So I think that's something that we can sort of try to think about together.
Absolutely.
Yeah.
And when I say it's individualized, we're coming from at a perspective of a lot of experience, a lot of years of doing survivorship. So some of the things that may seem like, okay, that's just how it is, we can build that, right? And there could be real concrete strategies that you're treated with this kind of ALL regimen. This is a kind of way that we could think about survivorship.
Yeah.
And some important, and something that's evolving and that, you know, you can be brought right there. One of the things that we're really thinking about now is thinking of it less about somebody needs to be seen every year, but or some particular interval, but more at touch points, at developmental touch points. So, you know, in the like before puberty, at a point, like in early adolescence, at a point in early young adulthood, in order to capture those issues. So that's another way of thinking about it and another way to create a survivorship care plan. But I agree, if one thinks about the regimens, one can think about how, what the resources are and how you might want to follow patients or think about their survivorship care.
Yeah. And I guess one other comment being that apart from the pediatric population, we actually see a fair amount of young adults as well, given that the population in general is younger. So this is for us as a team to think about this beyond pediatrics. Yeah.
Okay. Yeah.
Oscar, do you have a question?
Yes, thank you. Thank you for the good presentation. I have a concern about the last constellation, patient education, an important component of survivorship care. Yeah, this morning I got a case for 14 years with nasopharyngeal carcinoma, and the treating doctor was asking me, as this cancer, the key treatment is radiation, and seeing these side effects, the treating doctor was asking me if really it is necessary to do radiation. So this is a question I have maybe to everyone there to help us, because the child is very stable. He was at school, still at school, but is having nasopharyngeal carcinoma diagnosed with neck mets. And we have done a CT after, and they showed the mass, the nasopharynx mass, removed, now ready to go to radiation. So, but this, for this case, for example, on the counseling, we are obliged to tell all the things, all of these risks, so that we can do radiation. And here we don't do brachytherapy. It is not brachytherapy, not targeting one area. Yeah, thank you.
So I'll let Dave go.
I think, I mean, I think that's such a good example case to bring up, because it does speak to the fact that it's important to think about these things as you're talking about the treatment that the patient is going to get, and they have real impact on you know, what's going to be the right and appropriate treatment for the patient. I recall relatively recently, I think we've had a similar nasopharyngeal carcinoma case that we discussed, and I think balancing the potential for long-term side effects with the radiation is really hard. I know Dio has brought up the thyroid issue a couple times, but there are a lot of you know, there are a lot of late effects that can happen from radiation to that area that Lynda pointed out. I think sort of you know, that has to be balanced against, you know, where exactly the disease is, what the particular patient situation is, and what their likelihood of cure is. But I think sometimes that's why, you know, cases like that, it's really helpful for us to discuss as a group on the call and think about how we're informing the patient about the treatment that we're recommending, and you know, what's really going to be the right treatment.
Yeah. Okay, thank you.
Is that a case you think we should discuss next week?
Yeah, maybe this case will be discussed tomorrow at the shared clinic at Kanombe.
Mm.
So maybe we'll get the feedback. Yeah, thank you.
Thanks, Oscar. So we almost over time, but if there's any last questions or comments.
Okay.
Thank you so much for having me today.
Thank you.
Yeah,
Thank you.
thank you. That was great. Thanks.
It was wonderful. Thank you.
Lynda.
Yeah, thanks so much, Dr. Vrooman. It's great to have you. And to the Rwanda team, we'll be sharing the recording, just everyone else who could not make it today.
Thank you.
Thank you.
Thank you, Albert. Thank you.
Yeah. Thank you all. Have a wonderful day.
Thanks. Bye bye.
Thank you. Same to you.
Bye-bye.
Thanks, Lynda.